Hey everyone, this is Victor from Cyborg for Life, and today I have a very special interview for you. She's an exceptionally experienced orthopedic surgeon in limb lengthening and deformity correction in Montreal, Canada. Please enjoy the interview with Dr. Marie Gdalevitch. All right, everyone. Today we have a very special guest joining us. She is a world leader in limb lengthening and deformity correction at a private center in Montreal, Canada, specializing in multiple disciplines, including complex deformities, advanced field of limb lengthening. She's helping patients balance unequal leg lengths, as well as those stressed about their stature, so they can achieve their desired height and live a happy and fulfilled life. Please join me in welcoming world-renowned orthopedic surgeon, Dr. Marie Gdalevitch. Good morning, Dr. Gdalevitch. How are you?
Good. How are you?
Awesome, awesome. Well, I thank you so much for coming on and sharing your perspective on limb lengthening, because Dr. Asiag a few weeks ago, who I had on, spoke very highly of you, and I was like, I got to get this lady on. So, so a little bit about your background. You did your medical degree and residency at McGill University in Montreal, Canada, and fellowships in limb lengthening and deformity reconstruction at the International Center of Limb Lengthening in Baltimore. You've also published interesting peer-reviewed articles, including one on how heparin sulfate can negatively impact bone formation during lengthening. You're also the co-inventor of the free gliding screw that helps stabilize and prevent slippage of the capitofemoral physis in children with open growth plates so that they don't get premature growth arrest in their femur, which can lead to a leg length discrepancy. And you also travel to lesser developed regions in the world to treat those who have deformities, such as, those who were impacted by the earthquakes in Haiti. So to kick off our discussion, I just want to start off by asking how you became interested in limb lengthening.
So, like everything in life, it's sort of by chance. At the time, I was dating someone who was doing medical school in Israel. And I was in my third year of residency. And to be able to go over there to do an elective, I had to prove that they were doing something there that we didn't have access to in Montreal. So then I Googled and found this doctor, Mark Eidelman, that was doing the talar spatial frame and the hospital where my partner was working at. So I put all the paperwork together, ended up going there to do a 1-month elective. And like I said, just random chance, because I needed to and I wanted to spend some time with my partner at the time. And then that's how I found Mark. Mark was, he's a mentor and a friend, and he's the one who told me, if you want to do limb lengthening, deformity correction, you got to go to Baltimore. And so that's how I ended up going to Baltimore.
I see. Yeah.
I wasn't exposed to any of this in Montreal, so that was really by chance.
Wow, that's very cool. Well, we're glad to have you a part of the community. All right. So yeah, to lead off our discussion on limb lengthening, over the years, it's found several uses for, since its inception over 100 years ago, including correcting discrepancies, bone deformities, and even now to increase a patient's stature for those who just are unhappy about it, or even if they have some sort of form of dwarfism. So I want to ask you, how do you determine how much length the bone segments, either the femur or the tibias, can handle in leg lengthening specifically? For example, let's talk about cosmetic limb lengthening. Do you think it's safe to, x-ray a patient's bones, measure it, and then lengthen up to a certain percentage of their bone length? Or do you prefer to just, obviously just start lengthening and then observe along the way? And if any complications arise, you handle them as they come. What's your process?
My process is, so this 20% is in the literature, but it's pretty historic in my opinion, because I don't have that experience. And if you talk to, some of the people that taught me, they don't really dictate that in terms of learning anymore either. And we know that because we lengthen children's bones way more than 20%, and dwarf bones way more than 20%. And so I don't spend any time measuring the patient's actual femoral length and deciding if 20% will give them the height that they desire. Most people can get 8 centimeters out of their femurs. Even if you're talking about a 4'9" woman or a 5'2" guy, whatever it is, most people, or if they have a limb length discrepancy, we usually can go get the 8 centimeters safely. It's not the bone that'll be the issue. It'll be the tension in the muscles and the difficulty with contractures that stop us from lengthening further. So the way I present it, particularly to my stature lengthening patients, the first 2 to 3 centimeters, pretty easy, home run. Not hard. Most people can get that. The next 2 to 3 centimeters, medium hard. You're starting to get tired also. It's a process. You got to keep working on your physio, but I haven't had a patient not been able to get to 6 centimeters. Wow. The last 2 centimeters, more challenging. You need to be, that's where I become their cheerleader, and I sort of have to encourage them to keep going, They're tired, they're in pain, the muscles start to be a lot tighter. It's a little harder to get to that last 2 centimeters, but it's like a marathon. You just got to see the end goal, and if they're motivated, most of them can get there. So I don't really see it as a percentage. I really see it is very much a question of function. We never will allow a patient to lose function for gaining height. So I tell them off the get-go, the only thing that will stop us is if you can't get your full range of motion in your knee, then we're not going to be able to keep going. Or if you start to lose some kind of range of motion in the hip, we got to wait. We're going to get the motion back, and then we keep going if we can. So that's the only thing that'll stop us from continuing lengthening.
That's beautiful. It's echoing Dr. Asiag's interview. He said safety first, and then, desire second. So I love that. Okay. So I love to always bring up examples, and I have an example here. It's, let's say that we have a patient who's about 29 years old, and they're 5'2" in stature. It's a male patient, and they're thinking of gaining 5 inches in height, or, about 13 centimeters, which would be, across 2 lengthenings, quadrilateral lengthening for both the femurs and the tibias. Obviously, you just mentioned the soft tissues and the tension and everything like that would be a major culprit of, how far they can go. But do other factors come into play, such as age or, hygiene? What type of, along the way, is it just simply the flexibility of their muscle tension, or do you look at a whole picture?
Yeah. So when I see the patients that, especially those that want to do the quadrilateral lengthenings, it's very important for them to understand what they're getting themselves into. So the first thing I look at is proportion. So I want to show them, we sort of have a standing measurement. They put their arms to their side, and we see where their middle finger ends up in terms of where it ends up on their leg. If they're already pretty short in the arms, they're going to have to understand that getting that much length in their legs will cause a disproportion between the arm length and the leg length.
Right.
And that's where they might need to consider doing an arm lengthening. Okay. It's not that common, actually, to have such a disproportionate arm to leg length. Most people can get away with it, but it's something that you definitely need to consider, that the patient needs to be aware of before they embark on this process, because they won't know that until the end, right? So, and then the other thing I look at is I do a physical exam to see how tight they are in their muscle groups. All patients that come see me for stature lengthening have a physio program given to them a month ahead of surgery. Wow. So they do pre-stretching before we start. There's 2 reasons for that. One, we're in Canada, and for me to schedule their surgery takes a month. Right. So I have that luxury. Once they tell me they want to go forward, it usually takes me about a month to get organized with my private center. So they have that luxury to meet my physio ahead of time, and then we give them exercises that they do every day. It helps them prepare for what they're going to do after the surgery, but it also helps loosen them up for before the surgery. Now, if there's certain muscle groups that are tight, I will lengthen them or loosen them at the time of the surgery to aid with the lengthening. And then we usually time the femur to the tibia about 3 weeks apart. So we'll do the femur lengthening, the surgery, give them a little chance to recover, get on their feet, and then do the tibial lengthenings about 3 weeks apart. Gotcha.
Very cool. Yeah, I like that. That's essentially what a lot of the surgeons say. It's like that 3-week time frame is just enough to kind of give them that buffer zone. So, and let's say the patients who obviously want to get, take a full year between the lengthenings, would you suggest that they get the device, like the internal nails or whatever device they have, removed ahead of the next lengthening if they spread it out from a good amount of time? Or would you say that just keep them all in and then we'll take them all out when it's all said and done?
I mean, they can do it either way. Depends on how they see it. We can do it also at the time of doing the other surgery. So sometimes we tell them, we're coming in to do the tibial lengthenings. We'll take out the nails. And then that way, when we're done with the tibial lengthening, we can just take out the tibias after that. That's a nice way for them not to have to, pay for too much more surgery. The advantage in Canada for Canadian patients is that the removal of the nail is covered by the government, and the complications, if they have any, which so far, to knock on wood, I haven't had, but if they were to have any, they are covered by the government. When I have patients come from the US or from other countries, that's not the case. And so we try to do something to try to minimize their costs as much as possible, especially if they don't have access to having somebody else remove the nails in their home country. So if they're coming back for their tibias a year later, it's a perfect opportunity to take out the femoral nails and just do the tibial surgery at the same time.
That's awesome. That's great information. I didn't know that at all about the Canadian health. I mean, you guys have an amazing health system there. Awesome. Very good. Yeah. Being a surgeon with a vast scope of practice, how many limb lengthening procedures have you done since you started?
So I came back from my second fellowship in 2011.
Mhm.
And that's my main practice. Basically, that's what I do. So, and I see patients from all over Canada. I do kids and adults. So I'd say I do probably about 40 cases a year. That's combined with like my deformity cases that need lengthening and my limb lengthening cases, like all of that scope.
Right.
It's about 40 cases a year for the past, it's almost 10 years now. Yeah.
Wow. That's amazing.
Yeah.
Congratulations. That's a lot of
This is what I'm passionate about. This is what I like to do. And it was a process in Canada to build the volume, but that's why I do both kids and adults. And that's why I sort of focused my practice on that. That's why I have my website. All these things is because patients have a hard time finding the resource that they need to have the solution. You know, they've seen usually 5, 10 other surgeons before they've gotten to me. So all this education is super important for the patients.
Yeah, and that's one of my whole purposes of doing this, is to uncover the hidden gems like yourself and show them to the world. So very cool. Dr. Gdalevitch, the advancements in limb lengthening devices have greatly improved the efficiency of the procedure over the years. I mean, obviously for something like a severe deformity or, limb length discrepancy, you may have to use something like a external fixator, but for more acute and milder deformities, or just typical limb lengthening, you can use something like an internal nail, like the Precise or Stride nail. As a surgeon, what has your experience been like with these advancements in technology?
I mean, honestly, amazing.
Amazing.
When it's a no-brainer for patients who don't need to have an external fixation, especially for the femur. You know, we did one last week where she had a valgus deformity with a 3 centimeter limb length discrepancy. In old days, we'd have to use a frame. Yeah. And a frame on the femur is just painful for everybody. And we did the acute correction, put in the Precise retrograde, and she's doing the lengthening. I mean, it's just amazing, right? It really changes their life in a way that is, it's untangible. In Canada, it was a challenge to get these nails covered by the government. It's still a challenge. We have limitations. But the more we do them, the more we can prove to what extent it improves patients' quality of life. And for stature lengthening, the difference between even the Precise and the Stride is remarkable in terms of the recovery, in terms of how fast they get back on their feet, in terms of how fast they're independent walkers. It's amazing.
Wow, that I completely agree. I mean, I personally had the original Precise, and now I'm hearing stories of people with the Stride nail and how fast they're able to walk. I'm like, I wish I could have done that. So
yeah, it was more painful with the Precise for sure. It was much better than the frame.
Yes.
Comparatively with the Stride, it really is. We've made remarkable advancements.
I know, and it's incredible to see this happening along the way. And your patients, I'm guessing they love the same. They're giving you the same feedback. They're saying that they love the internal nails over the external fixators.
Well, the thing is that the ones that get the nails don't know the pain.
Yeah, that's right.
So it's hard for them to see necessarily the difference, although it's a much easier, they're back at work a lot faster, back at school a lot faster for the kids. So for sure they know, but a lot of them have seen the option of the frame and have come looking for the nail, and just looking at the frame, they're like, that's not for me.
Right.
So I think they can understand what they've gained, but they don't really feel it because they already have the advantage of coming
of the nail. Yeah. I personally had a external fixator. It wasn't for lengthening way back when. So I kind of know the difference. It was on the femur. It was a monolateral. So I know that, having that rigidity there and just physical therapy and sleeping was another thing. So
yeah, exactly.
It was terrible. Okay. So I'm going to move on to potential complications. Obviously that's part of the process. And, obviously we want to mitigate that as much as possible, but you said earlier that you haven't seen any major complications in your practice. But what is your method for staying ahead of the problems that could arise? Like, do you collaborate with your physio team or to see if the patient's getting tight along the way, or like you said, you stretch you check the patient's flexibility early on? But what other type of observations do you take into account when you're trying to stay ahead of those problems?
So let me be clear. I've had complications, just not in my stature lengthening patients.
Okay.
So for my either limb lengthening patients, it's obviously when you have a patient who has a functional discrepancy, or they have a tumor or an infection that you're treating, it's a different sort of ball game. Or if you have a congenital deformity, those are not the same as stature lengthenings, and so the complications are totally different. So we're going to focus on the stature lengthening patients.
Okay.
Right?
Yeah.
Okay. So right now, I haven't had any major complications for the stature lengthening patients. It's going to happen one day for sure. These are all things that happen to every surgeon. This is the part that patients find difficult because this is the part we don't control.
Right.
What we do is we try to mitigate as much as possible. So some of the things we do to mitigate is the preoperative exam. So my physio sees them ahead of time. We prepare them for their exercises ahead of time. We try to figure out if there's anything we need to do to prepare the body for the surgery ahead of time. Like we need to, get any medications on board, or they get seen by our medical team. And then they also, in my practice, get seen by one of my psychologists that is specialized for this patient subgroup.
Okay.
The main reason for that, I know that a lot of people don't necessarily do that step. The main reason for that for me is that it gives me a lot of information about my patient. So I'm not usually worried that if I'm sending them to see my psychologist, it's because I've already decided that they're a candidate for surgery. But it's mainly so that I can sort of have a bit more information. How anxious are my patients? How much support do they have? Like all these things that I get some of the information, but my psychologist spends like 2 or 3 hours with them, and I get a lot more information from her report that prepares me for what kind of patients I'm going to be dealing with and how much I'm going to have to be their cheerleader, how much support they're going to need for my team. So that's sort of information that I find extremely useful for helping these stature lengthening patients. It also prepares me for how happy they're going to be after the surgery. You know, how much other issues do they have with their self-esteem that are going to impact their success and their eventual happiness with their stature.
Yeah.
So that's one of the ways we prepare. The other ways, from a medical perspective, we get them moving early. I have a physio that's trained only for my stature lengthening patients.
Wow.
And they come and they see the patients in the hospital, and then they are their physiotherapist for the entire time. And so we have two scenarios for physio. One is that they can come to the hospital, or the other is that they can actually stay home. And my physio goes to them, which in Canada and Montreal in the winter, for instance, that's a huge advantage. So the physio goes to them because, you know, for patients who aren't used to the weather conditions that we can have here, getting out, if you're using crutches, slipping, I don't want anybody falling. So our physio, they go to their house, they spend an hour every day with them, they show them their exercises, they give them an app, they follow up to make sure they're doing their exercises on their app. So that's sort of how we stay on top of our patients. And then to prevent the bad complications like pulmonary embolus or a clot in the leg, I usually do give them some kind of prophylaxis.
Okay.
It depends on the patient. Most of the time, it's the minimum amount is the aspirin that they'll take for at least a month after the surgery.
Okay.
Sometimes we'll go as far as giving them the little injections for the first 2 weeks after surgery, depending on how mobile they are. If they're a patient that's moving really well, really fast, I'm not that worried. We'll go with the aspirin. If I'm more worried, we'll go with something that's a little stronger for the first 2 weeks to prevent any complications.
Gotcha. That is a very thorough process. I love it. And especially with the physio integration you have there, that's a really seamless process to make sure that they don't, develop any of those muscle contractures along the way, which is like probably the major complication that could happen, like you said. Very, very cool.
There are a few other tricks that we use along the way. So patients sometimes do run into some problems. One is that we stop lengthening and we give them a chance to catch up. But the other is that we can use Botox. So sometimes we've had to do Botox injections. That tends to paralyze the muscle temporarily, allowing it to relax. And obviously we can use some kind of bracings that we have different kinds of braces that we can use to help patients if they really need it. It hasn't happened yet with the stature lengthening patients, but I have had that experience with my other patients.
Yeah. I know I had a discrepancy. I had that definitely. Very cool. That's really cool. And do you prefer, like you said, that patients could go home for their physio and they, do you prefer in your opinion that they stay on site at your practice to get? You do.
So I don't usually give them the option unless they're really close and they can come back every 2 weeks. I need to see them every 2 weeks. Basically, I tell them every 2 weeks I need to see you. I do a physical exam, make sure we're not getting tight. We do the x-rays, evaluate how the bone is growing. I get a report from my physio, and I really trust my physio. So I'm not that keen on having patients do it elsewhere because physios who don't have the same experience may not be able to do the same magic. So I don't usually give them the option. I tell them they have to be here for 3 months. It takes 3 months to get the 8 centimeters, a little longer if they're doing 3 weeks later, the tibias. But that's basically what it comes down to.
I like it. It's safety. It's your protocol. So I love it. We'll stick with that. All right. So would you suggest that cosmetic stature lengthening patients prepare, besides just mentally, but physically and financially, if they're not from Canada and they don't have a health card for that, for complications that arise?
I mean, they need to have at least some kind of the finances backed up to be able to support a complication. Again, I haven't had too many, but if they need intravenous antibiotics, if they need to see one of our medical specialists, they need to have some kind of 20 to 30,000 Canadian dollars reserve fund for any potential of them having to stay in the hospital a little longer, whatever it may be. But we haven't had to use it too often, and we usually find ways around it. We really do, try for the patients not to have to spend more money. It's already a very expensive surgery.
Absolutely.
But they definitely need to be prepared, and the thing I tell patients all the time, there's a slim chance you'll get a complications. We're talking like less than 1%. But when it's you, it's 100% you. It's not 1% you. So once it's you, it's you. So then we have to deal with it. So just so that they understand that it's a 99% risk, okay, that you're doing fine, 1% that something will go wrong, but when it happens, it's 100% you that gets.
Absolutely. It happened. Yeah. So, and it can happen, complications do occur. So that's good to know. Dr. Gdalevitch, your research on how heparan sulfate, the proteoglycan, can reduce bone healing during distraction osteogenesis is really, to me, when I read it, it was pretty intriguing. And have you personally used any findings from this study to kind of like improve the formation of bone and the outcome of your leg lengthening patients, or
that study was an interesting study. I put about hundreds of little Ilizarov frames on the tibias of little mice. That was challenging surgery.
I was going to say.
And hundreds, really. I mean, I never want to see a mouse again. But the real thing that was interesting about that is that there are things that we're missing, I think, in the whole game of limb lengthening, and there must be something that we could do more of once we have the length to help the bone sort of solidify itself faster. Now, with the stride and the fact that we're loading the bone, we see a pretty fast consolidation, actually. So that's already improved dramatically the whole spectrum of limb lengthening. And the internal nail as well has helped with overall biology of healing. But there are a few other things that we can use. There's, a vibrating device that can help. There's a few other things that we're looking into, but I can't say that it's made a major impact on my practice other than figuring out that there's certain things that we still haven't figured out about how to make the bone grow faster.
Bone heal. Yeah, definitely. And that's, non-union is still a potential complication, but again, you guys are doing a great job in how you have the protocol set up. So what about stem cells? Do you find that helps boost any formation in bones post-surgery, or?
Well, there's a bunch of studies now coming out with that. It's of interest, I think. I think really what it comes down to, though, is load. The bone, biology and load. So from the biology perspective, I think the stem cells could be a potential interesting solution for patients who could have, cystic formation in their regenerate, where you can inject perhaps a stem cell and try to get it to heal. But oftentimes it comes down to being able to load the bone appropriately for the bone itself to recreate. Absolutely. And with frames, it was a huge problem because the frame would take too much of the load, and then we would dynamize the frame and so on and so forth. Again, with the nails, we're really not seeing the same problems because the patients are walking, and because it's an internal device, the load transfer is different. To
the bone more so, that the cortex. That's very, very cool. Awesome. Yeah, I know that the internal nail definitely, when I was able to start walking, when I was able to start weight bearing a percentage to like a couple of weeks later, the bone formation was like miraculous. It's crazy. So the stride nails, the mechanical stress is huge. So now I want to talk a little bit about pain, because prospective patients are always worried about how painful the procedure is going to be. Being a former patient, I know that can be a big issue for a lot of people. Do your patients seem to manage their pain well with the procedure?
Depends on the patient. Some patients, it also depends on their age.
Right.
Younger patients, and that's not their fault. So younger patients, like really in the teens to 20s, the real young patients, their pain receptors are through the roof, and that's protective. That's meant to be that way. That's how the body's made. So young patients typically have more pain than older patients.
Okay.
And that's in their biology. It's not their fault. But it's also because they have maybe some, less life experience. They have had to endure less pain. So that whole balancing act, it's a shocker for their body, and it's a shock for their psychology as well. But I have to say, most patients aren't prepared for the first 2 days after surgery. The first 2 days after surgery are tough. You're being poked and prodded. You have to pee. You have to try to get up. That's the first couple of days are really tough, and I tell them that ahead of time. By the first week, most patients are fairly comfortable again. And so then the marathon starts. So that was the surgery, but now you haven't actually gotten your length yet. So then the marathon starts, and that's a slower process. It's a lot less painful from like the initial surgery, but it's prolonged. So you have to have the endurance. It's a question of managing, their expectations and helping them stay positive. And again, being a bit of a cheerleader in this process, because that's what it takes to get to the 8 centimeters at the end.
Mm-hmm. Yeah, no, I completely agree. I think that's the thing. It's like pain is a very individual thing, and usually, as long as, like you said, you kind of prepare your patients ahead of time, that's really good. But do you follow any special pain protocol? Like, I know that for my like a pain medication protocol or anything like that, or
so we try to give them all the different modalities. Even though we're doing limb lengthening, we will give them the first couple of days of anti-inflammatories, which tends to be a pain reliever that works well for this kind of thing. We give them obviously the hard narcotic medications, but we try to give them, if I have patients that have really high pain levels, we'll give them a long-acting and a short-acting as a way to diminish the pain and also diminish the risk of addiction. So, this is something that we're also very aware of in Canada, I'm sure in the US as well. And one of the reasons why people sort of get addicted to pain medications is because if they need to start to take it at frequent intervals and then they get a tiny high from it and then a low, that creates this addiction profile. Gotcha. And so if we have patients that have high pain and we want to try to diminish that, we're going to give them a long-acting medication twice a day to try to diminish the global pain, and then just the short-acting ones just to help minimize when they're doing their physio, when they need to get up and sort of manage them like that. But I have to say most patients with Tylenol around the clock, the anti-inflammatory for the first 3 days, and the Dilaudid or morphine or whatever it is, they manage to do pretty well. When we do the lengthening, we tend to give them something as to help with the spasms as well, the muscle relaxant. So they have a standing order for Valium to help with the muscle spasms, and because we don't want to start taking narcotics when it's not going to actually help the style of pain that they're having. If you have a spasm, that's not going to help. So we want to give a medication that's going to actually help the spasm. Try to be sensitive to that. It's it's still not a walk in the park. It's not a haircut, but it's the first 2 days are the worst. That's really what it comes down to.
Yeah, I completely agree. I think it starts to fade after, like you said, that first week and a half, and then it's just a marathon. So yeah, very cool. So we mentioned this a little bit at the beginning. We talked a little bit about proportions and patients. You mentioned about the middle finger being about mid thigh and all that. What is your take on the patient? Let's say if they get femur lengthening and they see that their femurs are. Do you measure, like when you're doing the initial consultation? Do you measure their arm length, bone length, or do you just kind of, what's your process?
Proportionally, I look at them clinically. So again, they're standing the way they would normally stand with their arms to their side. And then, I would sort of show them what it would look like in terms of where their arms would end up on their legs if we went for 8 centimeters, for them to realize what the proportion would look like. And so if it's more than that, if it's the, 15 centimeters, then they have to see where their arms are going to end up on their legs as well, so that they can see themselves what the proportion looks like. I think, I'll tell them what I think, obviously. When I think that there's a problem with proportion, I let them know. I haven't had that yet, but it will come. There's for sure going to be somebody who's already leg long and arm short and then wants leg lengthening, and then they're going to need to do something about their arms.
But the arms, yeah, definitely. And that's exactly what I was going to ask about, arms after that. So very cool.
Arm lengthening, for achondroplasia patients or dwarf patients, arm lengthening is actually what gives them functional length. So if you were to think about it, functional leg length comes from reaching. So reaching, actually, if you lengthen your arms, you get more reach than if you lengthen your legs.
Right. That's true.
So from a functional length perspective, for achondroplastics, for instance, we tell them that the arm lengthening is actually going to help them a lot. They need it anyways, but from a reach perspective, you actually get more from your arms than you do from your legs.
Wow, that's a perfect.
Look like a monkey with your arms, legs. So,
well, that's going to be music to the ears of a lot of the, my audience, because they love to hear about arm lengthening. So you're going to be their hero. Very cool. So I want to go a little bit into the recovery aspect of the procedure, because obviously we mentioned that's super important. Now, you mentioned you have a physio who goes to your patients, and then also the patients can see them at the hospital there. But let's say that patient is from Vancouver and they want, they're going to have to come stay with you. But would they have to stay the whole lengthening time? You said the 12 weeks, or let's say that they would have that app with the physio. You just suggest they stay the whole entire time?
Yes, so I've had a patient from Vancouver. They've stayed for 3 months.
Did they? They did. Okay, good. So they're just going to have to stay. Very cool. And
especially Vancouver. I mean, Toronto, I have a few patients from Toronto. That's about a 5-hour drive, a 1-hour flight.
Okay.
Pre-COVID, that was doable. I didn't love it. But after, let's say, we started to develop, let's say, a good working relationship, let's say after the first month, if things were going smoothly, then I would let them go back and forth and see me every 2 weeks. And I'd have my physio communicate directly with their physio.
I see.
But I haven't, that's the exception, honestly. And if there's any problems, I make them come back and stay.
Immediately. Yeah. And just stay the whole
So,
time.
and that's really the proximity. And I have a few other patients from Ottawa. You know, it's a 2-hour drive. That's pretty much as far as it goes. Otherwise, they need to stay in Montreal. And most of them, it's a lot easier. You know, it's not that easy to move around. I mean, it is, but to fly and to go and wait in an airport or to have a 5-hour drive, it's not as conducive as you think for their healing. They're missing physio.
Right.
They're putting themselves at risk for clots. Like it's just not great.
Yeah, I completely agree. I think staying on site is a lot better. I lived in Baltimore with my hospital, which was 20 minutes away, but I was there every time. So yeah, right. Completely different. And does your package, does that include the physical therapy sessions? Yeah. Oh, it does.
So it does include the physio. It includes everything that has to do with the medical, but they do have to find their own accommodations. Usually we recommend an Airbnb. We have a few places that other patients have used. And the physio goes directly to them. So they can choose where they want to be in the city. It is a fun city to be in the summer, and there's lots to do.
Yeah.
So from that perspective, but yes, it does include that. It just doesn't include the stay. So where they can choose wherever they want to stay.
Okay, gotcha. Yeah, that's very cool. And you guys have recommendations for that, so that's good. And then for patients, I get these questions all the time. They're like, you know, how soon can I resume my normal activities like jogging, running, lifting weights, things like that? What's your like kind of time frame on those different activities?
I'm pretty conservative.
Okay.
The thing about the stride nail that people sometimes don't understand, it is full weight bearing nail for a certain weight. So, you know, and there's different limitations of weight on the nail, but usually for the patient size, we get the right nail size in, they're full weight bearing. But there's different loads other than just weight bearing. The twisting is not the same thing. Yeah. So when you start twisting on the bone, when there's a gap there, that's a whole different ball game in terms of, you know, going up and down the stairs, single leg, weight bearing is different, right? So I try to explain that to patients. You're going to pick up 40-pound weights in each hand and walk to sit down to start doing weights. You've just added 40 pounds to what so that's where I say no to all that. Basically, they need to focus on their physio until I have full bone healing. So they're allowed to walk, they're allowed to bike.
Right.
Beyond that, there's no impact sports.
Okay.
They can swim if they want. Those are the 3 activities that they're allowed to do during the consolidation period, during the lengthening, whatever they want.
Right.
But once I have full healed bone, it's a free-for-all. You want, no problem, no issues.
Okay.
But patients push hard on that, by the way. So, you know, they're done, they're feeling good, but I look at the X-ray, I'm like, well, we have 3 cortices, there's missing the last cortex, it's coming in, but you need to be patient. Well, can I start to box, or can I start, you know, lifting weights with my arms? Yeah, but the problem is you're going to pick up those 40 pounds, you're going to walk, and then you're going to sit down and do your weight. That's the problem. So there has to be, and I try to be as conservative as possible because patients only listen so far. So they'll listen to me, you know, so far, and then they'll start to do whatever they want. So, you know, we're conservative on that. We don't want to have you've gotten to the end. You're like done the marathon. The last thing you want is to have a problem at the end.
I completely agree. I was super conservative with my stuff. I think at best I had like a 10-pound dumbbell sitting in a wheelchair, and I only had one leg at a time. So I like your approach. I really do. Very, very cool. Let's see. Well, yeah, that's pretty much what I have there, Dr. Gdalevitch. I think you're a very experienced surgeon. You're a caring surgeon. You know, you match your patient's desire with safety. You keep that in the whole perspective for a very involved procedure like this. And you're looked upon by and highly regarded by several top surgeons in the field, including Dr. Asiag, who is a up-and-coming superstar as well. For anyone who's considering what's that?
He's already a superstar.
He's already, I know he is. He's awesome. For anyone who's considering limb lengthening with you and would like to consult or reach out to you, what's the best way to contact you?
The best way right now is on my website.
Okay.
So drmarieg.com. And that's mainly because my last name is super complicated. And basically from there, I have a secretary who takes all the requests. We're actually doing a lot of virtual consults right now just to avoid people having to travel, giving them all the information that they need, meeting with me for the first time virtually. And then whenever the opportunity arises to be able to travel here, then they can come and get the x-rays that we need and meet us in person and so on and so forth. But they basically go on, there's a contact us on the website. They send out an email saying they're interested, and my secretary will be in touch with them to set up an appointment.
Yeah, Miriam, right?
Yes.
Yeah, she is amazing. By the way, give her my regards. She's amazing. So, yeah, so I'll be sure to post all your website and links in the show notes so everybody can find you there. Do you have any final words for prospective patients who are considering you for limb lengthening?
I mean, I do it because I see that the patients are happy. You know, I have a very busy, it's not the same as in the US. I have a very busy public practice.
Hmm.
So I'm a busy person with, it's not something that I needed to add to my spectrum, let's say.
Right.
But I'm the only one doing it in Canada. And
Mm.
I started doing it because there was a need, because
Hmm.
there were patients that were going to do it in places that were dangerous,
Absolutely.
because they couldn't find the answers that they were looking for
Mhm.
in Canada, and perhaps the US was a bit too expensive for them.
Mhm.
It's still expensive, don't get me wrong, but
Yeah.
we try to keep the costs under control. We have a good healthcare system. The quality of life that they have here in Canada, generally, if they want to stay in Canada to get it done, we would prefer that they stay here so that we can keep an eye on not having to deal with them coming back from other places. I've had a bunch of patients go to other places and have to come back and deal with those complications.
Yeah.
So we try to avoid that. But basically, I started doing it for that reason. And honestly, the patient, they're some of my happiest patients. So for me, it's gratifying. I'm happy for them when they're happy. And
Hmm.
that's basically why I started doing it. And
Amazing.
there's a lot of education to be done still. You know, there's
Yes.
a lot of judgment. A lot of Canadian doctors, Canadian orthopedic surgeons are very against it. And
Hmm.
so, you know, I've never had trouble sticking up for patients that have the right reasons to do it. And so I think that's another reason why I started doing it.
Absolutely. I think you have a really good system in place to kind of make sure the patient is a good candidate. And I completely commend you for what you're doing. You're doing an amazing job, Dr. Gdalevitch. All right, everyone. That is Dr. Marie Gdalevitch from Montreal, Canada. If you are interested in reaching out to her, I'll have all of her links in the show notes. Dr. Gdalevitch, thank you so much for your time.
My pleasure. Thank you for doing this.
You got it. I hope you enjoyed that interview with Dr. Gdalevitch. She's an extremely passionate, talented, and thorough surgeon who fixes the crudest deformities and has lengthened numerous limbs, helping her patients get taller and achieve happiness in the safest way possible. If you're interested in reaching out to Dr. Gdalevitch, I've posted all of her contact information in the show notes. And until next time, this is Victor from Cyborg for Life, signing out.